obs and gynae, and I spend the rest of my time writing, lecturing, and various other non-clinical duties. So in this lecture, we're going to cover life on the labour ward, including labour itself, CTGs, analgesia, and emergencies. I will run through this at a fairly rapid pace, but as my colleague said there, don't worry, the lecture will be uploaded on YouTube and you can rewatch it at a slower pace. And as she said, I'm quite happy to take questions. If you pop them in the Q&A box at the end, I'll hopefully have time to go through as many as I can. So we're just going to dive straight in with the first question, and I'm going to give you 1 minute to read the question.
Five more seconds.
Wonderful, thank you all for answering that question. So let's talk about the Bishop's score. So everyone that presents in labour is assessed via a digital vaginal examination, usually performed by a midwife, to see how far on in labour she is. As labour progresses, the cervix gradually moves forward, shortens, becomes softer and dilates. At the same time, the fetus descends down into the pelvis, becoming palpable via the vagina. That's the station. So the station refers to how far down the pelvis the baby's head can be felt in relation to the spines. So let's just dissect the examination findings. So her cervix is anterior, that's 2 points. It's 1 centimetre in length, that's 1 point. It's soft in consistency, another point. 1 centimetre dilated, another point. And it can be felt at 1 centimetre above the spine. So that's spines -1, which is again 1 point. So adding all that up there, her Bishop's score is 6. I think I clicked that twice there, sorry. So the correct answer is C, 6. So we'll dive in with the next question. And again, I will give you a minute to read that.
5 more seconds.
Great, thanks for answering. I think most of you knew the answer to that one, well done. So in contrast to the first woman, this woman is nowhere near labour and would have a very low Bishop score. Her cervix is very posterior, it's long, it's closed, it's firm, and in fact she is attending for induction of labour. So let's think about induction of labour. Now there's many reasons for induction of labour, including problems with the fetal growth, if the pregnancy has gone on too long, if there's problems with the fluid or the placenta, problems with infection, and medical problems with mum. So generally, after being examined, if the cervix is not favourable, so if it's like this woman, it's long, it's closed, it's firm, we decide on a method of induction. So there's a few methods to help the lady on into labour. The most simple method is known as a stretch and sweep, and that involves inserting a fingertip, if possible, into the cervix and separating the membranes away from the cervix. Most women will have some form of stretch and sweep, with the midwives often performing this in the community at about 39 or 40 weeks. If the cervix is not favourable, the use of intravaginal prostaglandins is indicated. These help to ripen the cervix, helping it to move forwards, soften and shorten. These come in the form of either a pessary or a gel, which is inserted directly into the vagina as close to the cervix as possible. The next method is an amniotomy, or an artificial rupture of membranes, an ARM. And that can be performed if the fetal head is well engaged and you can actually reach to rupture the membranes. Oxytocin or syntocinon is a synthetic form of oxytocin, and that's used to stimulate contractions. That's normally used after the membranes have ruptured and is often used in conjunction with an ARM. So quite often a woman will have an ARM and go straight on the syntocinon. So let's check with the question again. And this young woman's attending for induction as she's post-dates. She's been pregnant for 40+2. And her cervix certainly doesn't sound very favourable, so it looks as though she needs some vaginal prostaglandins, and the only option here was the pessary option. Intravenous oxytocin, that's not appropriate at this time. That helps with contractions, and she's not yet in labour, she's not having contractions at the moment, so that wouldn't be indicated. Terbutaline, that's a tocolytic drug, so that's a drug that would stop contractions and would certainly be of no help in this situation. Intramuscular corticosteroids, these are given to promote fetal lung maturation. So they're given to a woman if she's being induced for labour, or if she's in labour if the baby is less than 37 weeks, just to help the lungs mature a little bit. And whilst artificial rupture of membranes can form a useful part of induction, this woman's cervix doesn't sound like you're going to be able to reach her membranes. So the correct answer there is A, vaginal prostaglandin E2 pessary. So we'll move on to the next question. And again, I'll give you a moment to read the question, and then the poll will pop up.
Five more seconds.
Great, thank you for answering. Again, most of you got that one correct, so well done. So let's just dissect this question a little again. So we've got another woman attending for induction of labour, and this time she's at a term gestation, so she's 39 plus 4. And the reason she's being inducted is she's had reduced fetal movements, and 2 or more episodes of reduced fetal movements is an indication for induction at term. She's already started the process and she's had her prostaglandin pessary. She's been examined and her Bishop score is 10. So it sounds like she's well on her way to labour, and she's had her membranes ruptured and she's started on syntocinon. So this is all sounding pretty normal so far. She's contracting well, her contractions are regular, occurring every 4 and every 10 minutes, lasting approximately 40 seconds and are of moderate intensity. And her CTG is looking good. So things are all going well. So let's have a wee chat about syntocinon. So I think I said a couple of slides before, it's a synthetic form of oxytocin, which is a hormone that's naturally produced, which augments labour. It's quite routinely used to optimise contractions and is administered IV via a syringe pump, which can be increased or decreased by the midwife. And the whole point of syntocinon is to achieve effective contractions. So what is effective contractions? We're aiming for 3 to 5 contractions every 10 minutes. Less than 3, we'd consider increasing the syntocinon. If it was more than 5, that's a bit too many and we'd consider decreasing it. Contractions should occur every 30 to 60 seconds and allow for a rest period in between. And they should be of moderate intensity. The intensity is quite subjective. It's assessed via abdominal palpation. The midwives are the experts. So if we go back to the question here, her contractions are pretty perfect, her labour's progressing nicely. Therefore, there's no need to be altering her rate of syntocinon and we can continue at the current rate. If her contractions were less than 3 in a 10-minute period, or were lasting less than 30 seconds, we'd consider increasing the syntocinon. And normally we increase it every 30 minutes until normal contractions or effective contractions are achieved. And if the contractions were more than 5 per 10 minutes, or lasting more than 60 seconds, or if there was any evidence of fetal distress, we would think about decreasing or stopping syntocinon. Again, terbutaline wouldn't be appropriate here as it's a tocolytic. Remember, it stops contractions, and we wouldn't normally use that if her contractions are going along absolutely fine. And everything is totally normal here, so there's certainly no indication to go for a section. So let's move on to the next question. And again, I'll give you a minute to read the question.
Five more seconds.
Thank you for answering. So another woman in labour. Sounds like she's been in labour for quite a while. She's becoming exhausted, but the baby is nearly here. So let's have a wee chat about the stages of labour. So the first 3 women we met were in the which this stage is quite variable. However, we do aim for about 1 centimetre dilatation per hour. Women that have had many births before tend to progress a bit quicker, and women who are having their first baby tend to be a wee bit slower. The second stage is the hard part and begins when the cervix is fully dilated and lasts anywhere from 2 minutes to 3 hours, and it ends when the fetus is completely delivered. Again, it's variable, with nulliparous women taking longer, and it's also longer if the woman has an epidural in situ. And the third stage of labour is after the baby is born and once the membranes and the placenta have been fully delivered. Let's talk a bit more about the nitty-gritty of the second stage. So sometimes you can hear this referred to as 2 stages in itself. The passive stage, which is where the uterus does much of the work and it's passively contracting and pushing the fetus down into the birth canal. The active stage is accompanied by an uncontrollable urge to bear down and push, and involves active pushing efforts from the mother, which quite quickly does become exhausting. Getting to the main event, the delivery of the baby. Now, this usually occurs following a set pattern of movements. When the fetus is coming down into the pelvis, it does so in a flexed position. So the baby's chin is tucked right down into its chest and it's facing either right or left. And its whole body is almost entirely sideways, as you can see in that first picture there. As the head begins to be delivered, the fetus internally rotates. So the face is facing the maternal back. So you can see that happening in the second picture there. The baby's head is turned around to face the mum's back. The head then extends, lifting the chin to facilitate delivery of the head, as seen in the third picture. As soon as the head is delivered, the fetus externally rotates back to that sideways position, facing the mum's left or right. And you'll hear this referred to as restitution, and that's what's seen in the fourth picture there. This allows for delivery of the anterior shoulder, so that's the topmost shoulder, under the mum's pubic bone, and then usually the rest of the body flops out after that quite quickly. Now, as I said, the second stage is quite variable, but it shouldn't be allowed to continue for too long, as it's an incredibly stressful process on both mum and baby. So in nulliparous women who have not birthed before, the second stage should be under 2 hours, and under 3 hours if an epidural is in situ. If it exceeds these numbers, it's seen as a prolonged second stage. And in parous women, so women that have had a baby before, the second stage should be under 1 hour or under 2 hours if there's an epidural. Any longer and it's termed a prolonged second stage. So if we go back to the question, she's certainly in second stage of labour. She's a nulliparous woman and she's got an epidural in situ. So she should have delivered within 3 hours. And as the question says, she's been dilated for 3 hours and she's been pushing for the past 2 hours. She's becoming exhausted. That's an indication for getting the baby out ASAP. As the head can be seen, it makes sense here to perform an instrumental delivery. There's actually no indication here for an emergency section. The baby is almost here and there's no indication of fetal distress. And actually it's very difficult to perform a section at this stage as the baby is so far down into the pelvis. And with the woman having been in labour and been pushing for 2 hours, there's going to be so much pressure on that uterus that she will bleed a lot during section. So actually we want to avoid that situation. Oxytocin, that's not correct. That's used to facilitate contractions. Like we discussed before, it's commonly put up if contractions are tailing off, if they're not strong enough. She's so close to having the baby right now, it wouldn't even have time to be useful. Allowing a further hour of active pushing, that's really not fair on mum. She's exhausted and she needs some help. And there's no indication for nifedipine. So nifedipine is another tocolytic and that would inhibit her contractions and it's got no role here. So the correct answer is operative delivery using chelant forceps. So we'll move on to the next question. Here's another woman in labour. I'll give you a moment to read that.
Another 5 seconds.
Great, thank you for answering there. So let's talk about cardiotocography. So the key is in the name there, cardio, heart rate, toco, contractions, and graphate means graphed out on a long piece of paper. So put simply, the CTG measures aspects of the fetal heart rate and the presence of contractions and tracks that over time. So when we're interpreting a CTG, we look at 4 main components: the baseline rate, which should be 110 to 160, the presence of accelerations. Now there should be accelerations, that's where the baby's heart rate speeds up in response to movement, in response to pressure. Variability, so that's how much the baseline rate varies by, and that should vary by 5 to 25 beats per minute. And decelerations are when the baby's heart rate drops, and they should not be present in early labour. So looking back at the question, we can see the correct answer there is A. In B, the baseline rate's only 90, so that's normal, that's quite abnormal. In C, the variability is not great, it's less than 5 beats per minute. In D, the baseline rate is above normal, so again, that would be not reassuring. And in E, we've got decelerations, which again are not normal in the early stages of labour. So it's quite clear the correct answer there is A. I think most of you guys got that, so well done. So another pregnant woman coming up. I'll give you a moment to read the question.
Five more seconds.
Great, thank you for answering. So like all pain, obstetric analgesia follows a pain ladder. There's lots of effective non-pharmacological methods that women like to use. So in this question, she was using exercise, she was bouncing on the ball, she'd had a warm bath. Most women will use nitrous oxide or Entonox, gas and air. This provides quick and effective pain relief, and you can take it as and when there's contractions happening with few side effects. Women are also recommended simple analgesia, so simple paracetamol. However, as labour progresses, stronger analgesia is required, and it depends sort of how this woman is, whether she wants to try with oral analgesia, or if she wants to try with IV or IM, or if she wants to go for an epidural. Usually an epidural is offered when a woman's in established labour, so contractions are happening and she wants to go ahead with an epidural. Pudendal nerve blocks, they are reserved for if an operative delivery is required. So if she's going to go for a forceps or if she's needing an episiotomy, that provides rapid regional anaesthesia, and that anaesthetizes the perineum, including the vagina, the vulva, the anal sphincter. So if we look back at the question, this woman's already used some of the non-pharmacological methods. She's already taken paracetamol and she's already using her gas and air. The next step, therefore, is to think about using opiate analgesia or epidurals. The most appropriate choice here I've put is diamorphine, which is administered IM. Now, I know a lot of you picked epidural there. The reason I've not put epidural as the most appropriate analgesia is usually we reserve it for women that are in active labour. She sounds like she's still quite early on. And the other reason for not going straight for epidural is this woman seems to quite like being mobile. She's finding moving around is helping. She's walking, she's using a birthing ball. And epidural does give you some level of motor block. And a lot of women end up on their back in their bed. So movement is not as easy if you've got an epidural on board. So that's why I've put diamorphine over epidural, but I understand why a lot of you have gone for an epidural. And that's not necessarily the wrong answer, but I've put diamorphine as the most appropriate. Patient-controlled analgesia, it's not used very often in obstetrics. And again, that's going to hinder her mobility because she is going to need to be hooked up to an intravenous pump at that point, which doesn't sound like it's going to be great if she's wanting to walk around and use her birthing ball. Ibuprofen, I hope nobody picked. Ibuprofen is contraindicated in pregnancy. And as discussed, a pudendal nerve block is used to provide regional anaesthesia if she needs an episiotomy or an operative delivery. So she's not quite there yet. So next we're going to talk a bit about sections, and I'll give you a further question.
Five more seconds.
Great, thank you for answering. So let's talk about caesarean sections. So as you all know, a caesarean section is delivery of the fetus via a direct incision through the abdominal wall. Now there's a few indications for an elective caesarean section. So elective is also known as category 4, so it's not an emergency, it can happen at any point over sort of a week-long period. So indications include if the woman has had a previous section, if she has a breech presentation or a transverse presentation, in twin pregnancies, if one of the twins is upside down, maternal genital herpes in the 3rd trimester, just due to the risk of transmitting that to the baby, if the mother is HIV positive, or if there's a placenta previa. So looking back at the question there, the only indication there for an elective caesarean section here is her being HIV positive. But let's look at the other options. Urea of 4.1, that's certainly abnormal. Urea generally won't go up above 3.8 in pregnancy, so this 4.1 could be a sign of preeclampsia or renal problems, so we can't ignore that and we certainly need to investigate that. Again, looking at option B, a hemoglobin of 7.8, that's not normal, she is anemic. Again, it's not an indication in itself for caesarean section, and we've also got to bear in mind that caesarean sections are often associated with more bleeding than a vaginal birth, so we actually want to avoid a section in someone that's anemic. But again, that merits further investigation, take a better history, see if she's symptomatic, does she need a transfusion? Looking at option C, a CRP of 198, again, that's not normal. CRP will rise a wee bit during labour, but shouldn't be up in the hundreds. That points towards some sort of infection or inflammation going on, and again, that does merit remember that rhesus negative women do need to have anti-D after any sensitizing event, delivery included. So the correct answer there was HIV positive. And just while we're on the topic of caesarean sections, here's another wee question on anatomy.
Five more seconds.
Great, thank you for answering. So I'm not sure if any of you have been on clinical placement in the labour ward yet or even scrubbed into caesarean section. So just to go through the anatomy there. So the first part obviously to be incised through is the skin. We then dissect through the subcutaneous fat to expose the rectus sheath, which is a sort of fibrous white rectus firm sheath. We then cut through that with either a scalpel or scissors. We'll then find the rectus abdominis muscles beneath. These are usually torn apart rather than cut. And beneath the muscle is the peritoneum. Beneath the peritoneum, we can then see the muscular uterus. The next stage is to incise through the myometrium, which is known as a hysterotomy, and that exposes the amniotic sac. The last stage is to incise through the sac, let out all that fluid, and deliver the baby. The uterus is then sewed up, the placenta is removed and the uterus sewn back up using sutures, and all the layers are replaced in reverse fashion. So the correct order there is skin, subcutaneous fat, rectus sheath, rectus abdominis muscle, peritoneum, myometrium, and then the amniotic sac. So we're just going to go through a couple of emergency situations to finish off. I'll give you a minute to read that question.
5 more seconds.
Great, thank you for answering. So let's dissect the question again. This woman is Paris with 4 previous vaginal deliveries. So we're mindful that her cervix might dilate super quick and she might fly through labour. She's had a reassuring CTG so far, but very suddenly it deteriorates following a gush of fluid. So it sounds like her membranes have ruptured. This is unlikely to be a placental abruption, as that's usually accompanied by pain and bleeding rather than this gush of clear fluid, this painless gush. It certainly doesn't sound like a shoulder dystocia. There's no mention of the fetus being delivered. Uterine rupture is generally only found in women that have had previous sections. She's got no other risk factors for a uterine rupture. And again, this is usually painful. And an amniotic fluid embolism, that usually presents like any other type of embolism. So like a pulmonary embolism or a stroke, depending on where the embolism has travelled to. So the most obvious problem here is an umbilical cord prolapse. So let's talk a bit about cord prolapse. So there's a few risk factors for cord prolapse. And that's a cord prolapse is when the cord descends through the cervix before the fetus. So it comes down beneath the fetal head and through the cervix. And what happens there is the cord is either crushed or it vasospasms, and that essentially cuts off blood supply to the baby. Risk factors include abnormal lie, so if the baby's sideways or upside down, if it's a multiple pregnancy, so twins or triplets, polyhydramnios, that's when there's lots of fluid, which can quickly wash the cord down into the cervix. If the head is very high and not well applied to the cervix, there's then space beneath it for the cord to pop out. And multiparous women. So I think her risk factors there was her multiparity. So she's had several births before, so that's her risk factor there. It is an obstetric emergency and it does necessitate immediate delivery of the fetus because it's no longer receiving an adequate blood supply, and it doesn't sound like it's in quite the right stage to be pulled out vaginally, so it sounds as though she's going to theatre for a section. So last question, last emergency.
Five more seconds.
Great, thank you for answering. So this woman's having a shoulder dystocia. The head's been delivered and the body is stuck, and the midwife has rightly called an obstetric emergency and the registrar is rushed into the room. So there's a few risk factors for shoulder dystocia. These are macrosomia, so a large baby, any personal history of shoulder dystocia, a large BMI, diabetes, if the pregnancy is post-term, so 40 plus weeks, or if the labour has been poor progress in the first or second stages. So the mnemonic HELPER is often used to remember the management of shoulder dystocia. For your finals, you really only need to know the first few, and that's why I've kind of put them in a bigger text. So obviously the first step is to call for help. If you're ever in this situation, call for senior help. The obstetric registrar will usually rush in and perform an episiotomy. This allows for more room in the perineum to in anticipation of an instrumental delivery. The part that you might be asked to help with is legs. So the legs need to be elevated up into the McRoberts position or the McRoberts maneuver. This is where the hips are fully flexed, so a knees to chest position with the thighs abducted and externally rotated. It's aiming to open up the pelvis and give as much space as possible. It's also tilting the pelvis slightly and giving the baby a bit more space to move under the pubic symphysis there. Another set of hands can be then used to perform suprapubic pressure, and that's literally pushing down just above the pubic bone to push that baby's head down under the bone in an attempt to dislodge that anterior shoulder that's been stuck there. Now, 80 to 90% of babies will be born with these simple manoeuvres. The next steps are thinking about entering the pelvis with either instruments or your hands to rotate or dislodge the shoulder. We can think about releasing the posterior arm, so the arm that's beneath, by sweeping it across the baby's chest. And finally, the all fours maneuver, which is known as the Gaskin maneuver, where we get the woman onto all fours, which again just changes the position of the pelvis slightly and allows for a little more room. If none of these things work, we need to proceed to cesarean section. So looking at these answers there, the only correct answer there is McRoberts maneuver. The other ones you probably don't need to know about, but I'll just tell you them just in case. So Gaskin's maneuver, I think I said that before, was getting the woman round onto all fours. Erb's maneuver, that's not a thing. However, it might be familiar to you as a shoulder dystocia can cause an Erb's palsy in the baby due to compression of the brachial plexus. So that's the classic waiter's tip position of the hand. That's quite common. Zavanelli maneuver, that is given the name given to pushing the baby back inside the mother's pelvis to prepare for a cesarean section. And the Mauricio Smelly-Vates maneuver is used in a breech delivery. So if the baby's body has come out and the head has got stuck, you definitely do not need to know that. So we've covered a lot of the issues that occur in the labour ward. We've talked about Bishop's score, we've talked about induction, prostaglandins, syntocinon, we've talked about stages of labour and prolonged second stage, we've talked about CTGs, analgesia, caesareans, and a couple of emergencies. So well done, guys, you've done pretty much everything that's going to go on in the labour ward. Let me just have a wee look at your questions and answers and see what I can answer there. So the first question there, do we need to know the Bishop's score off by heart? I highly doubt it. I certainly didn't need to know that for my medical school finals. What would be useful to know is what it looks at. So knowing about the cervix softening, the cervix coming more forward, the cervix dilating, you probably do not need to know about stations. That's kind of advanced exams things, you don't need to know that for finals. Somebody's asking about the question 4 about prolonged stage of labour. I'm just going to nip back to that question just so we can bring it up on the screen. So we're asking about question 4, query, has she only been at it for 2 hours? Looking at the question, remember second stage is from full dilatation to delivery of the baby. So although she's been pushing for 2 hours, she's been in the second stage of labour for 3 hours in total. She's been fully dilated for 3 hours. So when we're talking about prolonged second stage, it is the whole second stage, not just the pushing stage. So that's the reason why we're thinking about forceps. If the woman wasn't exhausted, if she was coping very well with labour, we might consider giving her another half an hour. Because like you say, she's nulliparous, she's got an epidural in situ. But I think the fact that she's becoming exhausted means that her pushing is not going to be effective. So she does need a little bit of help. There's a bit of clinical judgment in there. If she was absolutely fine and coping well, she might have been given another half an hour. Can I summarise the mechanism of action of terbutaline and nifedipine? So these are both tocolytic drugs, so they're drugs that are given when we want to stop contractions. So if at some stage in labour the baby is suddenly not coping and we want to go for a caesarean section, we want to stop contractions ASAP. Now, I think I'm remembering this correctly, and that nifedipine is a calcium channel blocker, and it blocks smooth muscle contraction. So that's the mechanism of action of that. I sort of remember it in calcium contraction, so calcium channels blocking contraction. Terbutaline, that is a beta agonist, and that promotes smooth muscle relaxation. So that makes the uterus want to relax. You'll maybe hear terbutaline being used in other illnesses such as asthma for the same reason. It's a smooth muscle relaxer. Why isn't IV fentanyl given? It's certainly an option. I don't see it used very often. Most women in labour labour find it a bit of a pain having to control their own analgesia. They want to concentrate on their contractions. They don't want to be thinking about pushing a button. It certainly is an option, but the reason I put it as not an appropriate option here is the woman was quite mobile. She was walking around the room. She was using her birthing ball. Being attached to an IV is going to hinder all of that. So that's the reason why I thought fentanyl wasn't an appropriate option there. So I think we've gone through all the questions and answers there. If there's no more questions and answers, I'd be really grateful if you fill out the feedback form. And like I said, I think this gets uploaded into YouTube in the next couple of days. So feel free to watch it on YouTube, comment on the video if you've got any further feedback. Cool, well done guys.
I think there's one more question that's in the chat. I don't know if you can see it.
Let's have a look. I think that's the same question, so about the prolonged second stage, the prolonged stage of labour.
Oh, sorry, I didn't realise it's the same question.
Yeah, same question, yeah, that's okay.
Thank you to everyone who's filled out the feedback form. To anyone who hasn't, the link to the feedback form is in the chat and we'd really appreciate it if you could fill it out.